Here we will review an approach to nephrolithiasis. Today we will start with learning objectives as follows. After this short video, you will be able to recognize signs and symptoms of nephrolithiasis, learn how to diagnose nephrolithiasis, understand when to reach out to specialists in the setting of complications, and at the very end, implement a standardized approach to evaluating and treating nephrolithiasis via a practice question. Signs and symptoms of nephrolithiasis or kidney stone include renal colic. This pain waxes and wanes anywhere from 20 to 60 minutes, and this pain can migrate as the stone migrates. Hematuria is evident on urinalysis. Sometimes it is gross and frank hematuria. Nausea and vomiting can present with nephrolithiasis, and dysuria and frequency occur more frequently when the stone is distal in the ureter. The big takeaway I want you to understand from this diagnostic approach is if the patient is pregnant, please get an ultrasound. Otherwise, the standard of care for nephrolithiasis is a non-contrast CT. Here is a nice flow chart reiterating imaging modalities. Arrows as above show examples of stones confined to the kidney. Notice on ultrasound on your left there is a large white circular stone, and on your right you can see how an artist drew the stone in yellow with shadowing below as an acoustic shadow. Now that we have reviewed signs, symptoms, and imaging, let's dive into management of nephrolithiasis. If your patient has concomitant AKI or anuric, please consult urology. Otherwise, treatment includes 1. Stone removal, and 2. Controlling the pain. You can pause the video here if you would like to review this table. However, to simplify, I want you to remember the numbers 5 and 10. If the stone is less than 5 millimeters in diameter, it should pass spontaneously. For stones larger than 5 millimeters in diameter, there is a progressive decrease in the spontaneous passing rate, which is unlikely with stones greater than or equal to 10 millimeters in diameter. Proximal ureteral stones are also less likely to pass spontaneously, and despite alpha blockers, the stones larger than 10 millimeters need urological evaluation. In summary, the stone needs to be removed either through passing, the patient passing the stone themselves, straining the urine, or removed via urological procedure. Pain control includes NSAIDs when patients have normal renal function. Most stones are radiopaque on imaging, although uric acid stones often present as radiolucent. An extensive but not all-encompassing list is displayed for your viewing. Last but not least, we will implement a standardized approach to evaluating and treating nephrolithiasis. I wrote this question here. A 54-year-old woman with past medical history of hypertension, diabetes, frequent UTIs presented to the ED with blood pressure of 84/42, a heart rate of 110, a temp of 39C, and a respiratory rate of 16. Her UA is significant for 50 red blood cells and specific gravity of 1.028. She is ill appearing with complaint of groin pain. Imaging as seen below, and she got cefepime times 1 dose in the ER. What is the next best step? You can pause the video here if you need more time to review the answer choices. The correct answer is E, urology. So this image is actually an X-ray showing a large staghorn calculus, which is commonly formed by struvite stones. These stones in particular are too large to be managed by pure medical management alone, so these stones need a surgeon to gain source control. While morphine and ketorolac are great options for pain management, the next best step is consulting urology. Tamsulosin is a great alpha blocker that can affect smooth muscle, aiding in passage of stones usually less than or equal to 8 millimeters in size. This concludes this video. If you have any questions, please reach out, and thank you so much for your time.